Crush syndrome is a potentially life-threatening systemic condition. Crush injuries are the result of physical trauma and ischemia to tissues secondary to entrapment of body parts by compressive forces. If a significant muscle mass is involved, crush syndrome can develop. Crush syndrome occurs following the reperfusion of injured muscle mass during rescue. Effects may be acute or delayed onset. In the acute setting, the main concerns are electrolyte imbalances, predominantly hyperkalemia, which can cause dysrhythmias, hypovolemia, and metabolic acidosis. Delayed effects may include renal failure, acute respiratory distress syndrome, coagulopathies, and severe sepsis. Preparation is key to successful rescue. Many of these injuries occur in the context of structural collapse, natural disasters, or dangerous industrial settings, so scene safety and management of hazards is paramount. All treatment must be carefully coordinated with rescue efforts, and in some situations, it may be appropriate to delay rescue until appropriate level of medical care is available. Preparation begins with a thorough assessment of concurrent injuries, and comorbidities should not be overlooked. Hypothermia should be assumed, and critical injuries such as pelvic fractures, femur fractures, and thoracoabdominal injuries must be recognized early. Following assessment, analgesia and aggressive fluid management are reasonable first steps. Patients with crush syndrome are subject to shock, so oxygen administration is indicated to maintain an SpO2 of greater than 94%. In some cases, it may be appropriate to apply a tourniquet proximal to the injury site on an entrapped extremity prior to releasing the compressive force. In cases involving large amounts of entrapped muscle tissue, preparations should be made in anticipation of cardiac arrest. Vascular access should be established, whether by IV or IO if it hasn't already been done, and 1.5 to 2 liters of normal saline should be administered. We're now concerned with the pretreatment of electrolyte imbalances such as metabolic acidosis and hyperkalemia. Sodium bicarbonate is an appropriate alkalinizing agent for treating metabolic acidosis. 1 milliequivalent per kilogram IV or IO slow push will buffer or neutralize excess acid, raising the overall pH. Treatment of hyperkalemia in crush injuries is the same as the treatment of hyperkalemia in any other setting. Calcium chloride may be considered, but care must be taken to prevent calcium chloride from mixing with sodium bicarbonate during administration and precipitating calcium carbonate. Sodium bicarbonate and calcium chloride should never be administered simultaneously, and ideally never through the same IV line. If it is necessary to use the same IV line, it must be thoroughly flushed between medications. Typically, calcium chloride is given 1 gram IV over 3 minutes. Calcium chloride should never be given IM or subcutaneously, and it's important to ensure the patency of the IV line to avoid extravasation and tissue necrosis. Salbutamol can be given continuously, and doses of 10 to 20 milligrams given via nebulizer are common. Salbutamol is a selective beta-2 adrenergic agonist with some beta effects. More importantly, salbutamol reduces serum potassium levels by increasing the shift of extracellular potassium into the intercellular space. IV dextrose and insulin together are part of a standard hyperkalemia regimen, but insulin is rarely carried on the emergency response setting, and expert consultation should be undertaken prior to administration. K-Xylate, or sodium polystyrene sulfonate, is a potassium binder. It is indicated in the longer-term treatment of hyperkalemia, but because of its relatively delayed onset of action, it has limited utility in the emergency setting. There's plenty of time to gather appropriate labs and have expert consultation prior to administration of K-Xylate. Once ongoing urinary production has been verified, mannitol 20% may be considered. Caution should be exercised in managing the airway on crush syndrome patients. If a rapid sequence induction is undertaken, succinylcholine is contraindicated due to the potential worsening of hyperkalemia. An alternative like rocuronium must be used. If you found some value in this review of crush injuries and crush syndrome, visit us for more at cmesurfer.com.